Most of the babies that we see in ED with bronchiolitis are actually going to be able to go home. Some of them are going to need to come back though, and that's the key here. When I'm thinking about discharging a baby with bronchiolitis, the thing that I most want the parents to understand is that this is an illness that means that their baby might get a bit worse before they get better, and that some of them will need to come back as a result of that. The role of parents is absolutely critical here. And so before they go home, we need to make sure that they have a good understanding of what they're looking out for, and that they also feel confident to manage their baby at home, that they're going to be able to get back if they need to. In general, we're going to be discharging babies who are consistently saturating at 92% or more and who are able to maintain their level of hydration. Now, we do tend to get a bit obsessed about numbers in bronchiolitis, particularly when it comes to respiratory rate and feeding volumes. But there are a couple of more helpful ways to assess whether a baby is ready for discharge, and that parents can use when they get home to decide whether they can stay at home or whether they need to think about coming back. We want babies to be able to feed enough to maintain their level of hydration. So clearly that means that their respiratory effort is not sufficient enough to be able to compromise that. Some babies are going to be able to feed perfectly happily with a respiratory rate of 60, and others will be really compromised with a respiratory rate of 40. Really, we do need to be thinking about ability to feed rather than respiratory rate. I tend to say to parents when I'm discharging them home that I want their baby to be waking for feeds on their own, to want to feed, and to be able to feed without getting too breathless or without getting so snotty or blocked that they're just not able to feed. Similarly, the volumes of feed that we want babies to take in order to be able to be discharged or to stay at home is another area of potential obsession for us. We tend to think about, saying to parents that their baby needs to be feeding at kind of 50% or more. That's actually quite difficult to ascertain, even in a bottle-fed baby, but especially in a breastfed baby. What we actually want is for babies to be able to maintain their level of hydration. I tend to say to parents, just keep an eye on baby's nappies. Subconsciously, every time you take a nappy off, you'll just kind of hold it in your hand and weigh it and see how much urine there is in there. What we want is for your baby to be having at least 3 wet or damp nappies in 24 hours. And that shows that they're feeding enough to maintain their level of hydration. When we're thinking about discharging babies with bronchiolitis, we're going to give special consideration to those higher risk groups. So those obviously are going to include babies under the age of 6 weeks, ex-premature babies, and those with other comorbidities. Those babies are particularly vulnerable to bronchiolitis, we know that. It doesn't mean that they're not going to be able to go home, but I am clear with parents, if I'm discharging those babies home, that their child is more vulnerable than the average, and that they should have a low threshold for coming back. I want them to understand that they are managing risk with us, and that we are in this together, and that we are making sure that their baby is safe to stay at home together. Where there's a language barrier, or where there are other barriers to parental understanding, or possibly where they've had previous experiences in and out of hospital that may lead them to feel less confident about managing their baby at home, then we need to take extra special care. This might just mean getting an interpreter. It might mean an additional period of observation, and for some parents that might mean that they just need to stay a bit longer or stay overnight. The key here is that we want parents to feel confident to manage their baby at home. I use this period of safety netting advice to discuss parental smoking or anyone else smoking around the baby. Clearly that's a good opportunity to talk to parents about cutting down or ideally eliminating smoking in order to reduce risk to their baby, both in this illness episode and more generally in the future. As a final word, I like to say to parents, no one's going to think badly of you if you come back. Nobody's going to judge you. We're not going to think you're a bad parent for not being able to cope at home. We want you to recognise that we know that your baby might get worse before they get better, that they might need to come back again for assessment and may or may not need to stay at that stage. It doesn't mean that you shouldn't come back. We want parents to be able to use their gut instinct. So if they don't feel that their baby is right, absolutely they should come back, And that's the final message that I always give them as they go out the door.